everybody. Today's topic is on bleaching. We know there are different types of stains that can be produced over the tooth structure. Like we have the extrinsic stains, we have the intrinsic stains that can be produced. So always a discoloration because of a external beverage like beverage drinks or any cool drinks or etc. can produce a surface generalized discoloration over the tooth, and even any intrinsic reasons or any systemic factors can also lead to a discoloration that is present within the tooth. So any of these cases, whether it being an intrinsic or whether it being an extrinsic stain, the proper identification of the type of stain is very necessary, because we have to know whether it is a tooth related or if it is like a necrotic pulp related factor. So every time a diagnosis of the stain that is present is very much mandatory, so that we can adjust the treatment accordingly for a vital and a non-vital. So the topic is for bleaching. So tooth staining is any change that is in the hue, color and translucency of the tooth due to any cause of cause because of restorative filling materials, drugs that can be both systemically and topically applied drugs, or a pulpal necrosis or a hemorrhage which can be responsible. So the tooth staining can be because of a patient related factor and also dentist related. If it is a patient related factor because of a pulpal necrosis, intrapulpal hemorrhage, calcific metamorphosis, age developmental defects and tetracycline staining. Then dentist related factors can be pulp tissue remnants, intracanal medicaments, obturating materials, amalgam, pins and post, resin composite. So these are the patient related and dentist related factors that can cause staining of the tooth. Now, proper identification, after the proper identification of what reason is the staining caused, we have to go for a bleaching. So whether to go for a vital bleaching or a non-vital bleaching is the another question that arises there. So bleaching is a procedure which involves lightening of the tooth of a color, or lightening of the color of the tooth through the application of a chemical agent. That is the word here, chemical agent, to oxidize the organic pigmentation that is present within the tooth, is the definition which was given by Sturtevant. Okay, so that is the procedure of lightening of the color of the tooth by application of a chemical agent so that it can oxidize the organic pigmentation that is present within the tooth. So this is the mechanism of action and the saturation point. So when we apply hydrogen peroxide, it is split into water and peroxide radical O2 minus, or the free radical, oxygen free radical. So this radical is responsible for the bleaching action. So so when there is application of hydrogen peroxide, it can penetrate through the tooth, and this uh, reaction, this oxygen radical or the peroxide O2 minus free radical is responsible for the whitening action of the tooth. So there is a point at which where there is no penetration of the hydrogen peroxide material into the tooth surface, and there is no production. Once it reacts, the production of this radical is responsible. So there is a point at which there is no action for the oxygen free radical onto the tooth surface. If the hydrogen peroxide enters also, there is no action for the oxygen free radical or the peroxide ions to act or to oxidize the tooth. So it is that point which is called as the saturation point. The saturation point is the point we have to understand where there is no effect in the bleaching. So always the patient comes, if the initial shade was recorded as 3, if the initial shade was recorded as 5M1, and the when it became 3M1, the shade is okay by the patient. The shade for the patient is okay. So we have to make one more shade lesser than this, and then we have to stop the treatment. That is the ideal protocol that is followed. And here we have to know that H2O2 gets split into O2 minus, that is the free peroxide ion, which is responsible for whitening the tooth. And there is a point at which the peroxide radical cannot exert any of its whitening action, and that point is called as the saturation point. Now we'll go to the techniques for bleaching. We have the extracoronal bleaching that is done outside the tooth surface, which is also called as the vital bleaching, and we have the intracoronal non-vital bleaching. So the vital bleaching is mainly four types. So the vital bleaching we have mainly, first one is the night guard bleaching or the matrix bleaching. Night guard, matrix bleaching. Then we have the power bleaching. Then we have the over the counter technique, that is the OTC, over the counter technique. And we have the walking bleach or the inside outside bleach technique. It is a walking bleach technique that we have in the vital bleach. So these are the four techniques of vital bleaching technique. So before going with a vital bleaching technique, we have to recall the patient. We have to see the patient's oral status. That is, the first test that we can do is the air test. That means from the three-way syringe, we can blow dry the patient's oral cavity. If the patient presents with any sensitivity or seeing the enamel thickness or the generalized discoloration of the patient, assess the enamel thickness that is present. So accordingly, we can modify the treatment modality. That means anyway, for vital bleaching technique, we have to administer the patient with a with a desensitizing toothpaste. So we can plan accordingly whether to prescribe the patient the desensitizing toothpaste either before the treatment, the bleaching treatment, or during the bleaching treatment. If the patient complains of sensitivity in the initial air drying itself, we can administer the patient 1 to 2 weeks of prior desensitizing toothpaste and then start with the bleaching procedure rather than going with a bleaching procedure as soon as the patient enters the clinic. So once we do the blow dry the patient and we understand the enamel thickness is less, we prescribe the patients almost 1 to 2 weeks prior a desensitizing toothpaste. So that is the first step that we have to follow, desensitizing toothpaste. Okay. Then accordingly plan the treatment, night guard, power bleaching, over the counter and walking bleach technique. This walking bleach technique is there in non-vital also, where we can either in this type of walking bleach technique we can place 30 to 35 percentage of hydrogen peroxide or even 10 percentage of carbamide peroxide is also sufficient. This carbamide peroxide and hydrogen peroxide both are same, but the action is that we need peroxide radicals to act upon. Okay, that is the main aim of our bleaching. So in walking bleach technique, we can place 30 to 35 percentage hydrogen peroxide or 10 percentage of carbamide peroxide. So in this technique, we can place it over the tooth surface with a proper rubber dam isolation. So rubber dam isolation is mandatory in all the in any of the bleaching procedures, where we have mentioned that even using extra heavy sheet rubber dam is also recommended in case of bleaching technique. Okay, extra heavy sheet. Once we properly isolate the tooth surface, application of the following agent, and this should be replenished every 5 to 8 minutes. Every 5 to 8 minutes, 2 to 3 times, this agent has to be replenished. That is called as the walking bleach technique, and the patient is sent. So that is the first appointment walking bleach vital technique that we do. Next technique is the night guard or the matrix bleaching technique, where the patient is asked, and in the first or the second appointment an impression of the patient's upper and lower arch is made using alginate and a biostar fabricated tray, where we can see in orthodontic department we can see that a biostar fabricated trays are made. So that trays are fabricated and the patient is given the bleaching solution. Patient is sent with the tray and the bleaching solution, and the treatment is followed. And here in night guard bleaching, we have to make sure the patient selection is very important. That means if the patient is not willing to turn up after one application, we have to see the patient's attitude towards the treatment. If the patient is so adamant that she cannot come or he cannot come, means don't go with night guard bleaching. Always clinician prescribed treatment is a walking bleach technique or the power bleaching technique. We have to be confident with the patient's attitude before sending the patient for a night guard bleaching. If the patient doesn't turn up, there won't be results and the patient would complain about the clinician. So night guard bleaching is always the patient has to be accepted by the clinician properly. So the patient is given the tray along with the bleaching agent. That means almost it is again 30 to 35 percentage, 10 percentage carbamide peroxide in the range of this material. Then the patient is asked to wear this material for 4 to 6 hours. For night guard, it is 4 to 6 hours. If the patient complains of sensitivity, we can go with a much lesser range of hydrogen peroxide, almost 10 to 15 percentage hydrogen peroxide also. So that is about the night guard bleaching. Then we have the power bleaching, where this is also done in a clinical setup. In power bleaching technique of vital bleaching, the agent is applied, that is 30 to 35 percentage hydrogen peroxide and 10 percentage or 10 percentage carbamide peroxide is applied. And power bleaching, the name itself suggests something is activating. We can activate this solution using a light. We can either use our curing lights, that is the quartz, tungsten, halogen light, argon, plasma arc, halide lights, etc. Or we can even use lasers. Lasers are also used for activation. So this activation can increase the amount of peroxide ions that is released at a much faster rate. If the other conventional measures takes 10 minutes, this can almost release the peroxide ions within 2 minutes. So that is the effect of using power bleaching. So there is more amount of peroxide radicals that is released and also at a much faster rate. And in power bleaching, curing lights can be used and lasers can be used. The most commonly used laser is KTP laser, which is very much efficient. Diode laser or carbon dioxide lasers are rarely used. KTP laser along with erbium family lasers, argon lasers can be used for power bleaching. And the main problem in power bleaching is that we have to see that the temperature rise should not be beyond 2 degrees Celsius, because if it is beyond 5 degree or 10 degree, there are two detrimental effects for the pulp. When it is above 5 degree, it can cause irreversible pulpitis, and when it is above 10 degree, it can even cause a necrotic pulp. So the 2 degree above 2.2, that is a maximum recommended temperature. It is a viva question or for an e question. 2.2 degrees Celsius, it should not go beyond that unless we are sure it should not go beyond that. If it goes beyond 5, it can cause irreversible pulpal damage, and if it goes above 10 degrees Celsius, it can undergo a necrotic damage. So that is about power bleaching, where we use either the normal clinical curing lights that we have, or we can use specialized lasers to enhance the activity of the peroxide ions at a much faster rate. Next, we have the over-the-counter bleaching technique. That is again the other method for a vital bleaching technique, where we can use over-the-counter techniques are what the patient can use otherwise. Like, it is not a clinician recommended technique. There can be dendrifices containing bleaching agents. There can be gels of that is containing a bleaching agent. There can be whitening strip, etc., that can be used as the over the counter bleaching techniques. So these are the main four techniques for vital bleaching: night guard, matrix bleach technique, power bleaching, over the counter and walking bleach technique. The recommended agent is 30 to 35 percentage hydrogen peroxide and 10 percentage carbamide peroxide. So this is the most commonly used for vital and non-vital bleaching. Now coming to the non-vital bleaching technique. Again, we have four techniques here. That is the walking bleach. We have the modified walking bleach technique. Then we have the inside outside technique. Then we have the power bleaching. So what is the difference between a walking bleach and a modified walking bleach technique? Walking bleach technique is using hydrogen peroxide with water. That was the most traditional method of a bleaching solution which is used in non-vital bleaching. But in the modified walking bleach technique, hydrogen peroxide was mixed with carbamide peroxide. Okay, so this is the modified difference between walking bleach and modified walking bleach technique. The inside outside technique is that is for non-vital bleaching, the obturation of the tooth has to be completed and the tooth has to be intact. So before all these techniques, I need to say that there are two ideal requirements for a non-vital bleaching. Ideal requirements, that is mainly 2 points. One, it should be RC treated or root canal treated with proper obturation, with a proper sufficient obturation up to the CEJ. Obturation up to the CEJ. And the next point is that the tooth should be intact. Tooth should be intact. If the tooth is not intact, if the tooth almost more than 50% of the tooth structure is lost, we cannot go for a non-vital bleaching procedure. Okay, so the tooth as such should be intact and also obturation should be complete for a non-vital bleaching. And these are the two techniques, that is a four techniques. Now, walking bleach is hydrogen peroxide with water. Modified walking bleach is hydrogen peroxide with carbamide peroxide. Then we have the inside outside bleaching. The inside outside bleaching is, inside is what we place hydrogen peroxide mixed with carbamide peroxide, and on top of that, on the extra coronal outside, we place hydrogen peroxide. Okay, so this technique of inside outside bleaching, here inside what we place, that is the hydrogen peroxide and carbamide peroxide, is how we mix them into a paste, and the filling material, that is the gutta percha from the canal, it is at the CEJ where we have to terminate the obturation material. We have to remove 1 to 2 mm of the gutta percha up to the level of below the level of CEJ. Place an intra orifice barrier. Okay, if suppose this is the root canal treated, this is the CEJ. Till here we remove the GP. GP is removed from here, and we place this material, is what we place the bleaching agent. So we cannot directly contact the bleaching agent with the gutta percha that is present. So we need to place almost 0.5 to 1 mm of intra orifice barrier. That is a barrier which is placed between the bleaching agent and between the gutta percha. So that is the intra-orifice barrier, is what is it called as. So we have different intra-orifice barriers that can be placed. We have biodentin, we have MTA, we can place even glass ionomer cements. In normal clinical scenario, we can place glass ionomer cement as the normal barrier. We have to take an X-ray. We have to see that the barrier is properly placed after the GP. Once it is properly placed without any, make sure that there are no voids in the intra-orifice barrier that we place. Over that, we can place the paste that we have already prepared with hydrogen peroxide and carbamide peroxide, and that paste is applied over the intra-orifice barrier, and it is sealed using a cotton and glass ionomer cement from the orifice filling. Okay, so this is the inside-outside technique that we follow. Then we have again power bleaching technique here, where we keep the material over here as usual, as the material is placed again inside the in after the intra-orifice barrier. This mixture is kept and the light is activating this technique. So here there is almost, when there is a 10-degree, here it is already non-vital, we need not bother about the temperature rise causing pulpal damage, because already it is a case of a non-vital bleaching. So if there is a 10-degree rise in the temperature, there is almost 10 times more release of peroxide ions. Okay, so 10-degree rise in temperature, there is 10 times more increase in the peroxide radicals. Peroxide radicals. So this is the techniques of non-vital bleaching. So those are the vital and non-vital, the four procedures that is under vital and non-vital technique. Now, the materials that is commonly used for this vital for bleaching are hydrogen peroxide, carbamide peroxide, and sodium perborate. For extracoronal bleaching or for the vital bleaching, we can use hydrogen peroxide and carbamide peroxide, and sodium perborate can also be used for intracoronal bleaching or the non-vital bleaching. So coming to the hydrogen peroxide, which is a commonly used concentration, is 30 to 35 percentage, which is also called as superoxide or perhydrol. It is also available in gel form when silicon dioxide is added as a gelating agent. It is activated by composite curing light, as mentioned earlier, or even with lasers. Then we have carbamide peroxide, also known as urea hydrogen peroxide, available in the concentration of 3 to 45. So most commonly is used is 10 percentage, which releases 3 percentage hydrogen peroxide and 7 percentage urea. This is the concentration that is commonly used. And the popular commercial preparations 10 percentage with a mean pH of 5 to 6.5 is used. So the concentration is 10 percentage. So when 10 percentage is used, this it is splitting into 3 percentage hydrogen peroxide and 7 percentage urea. So the solution of carbamide peroxide, as mentioned earlier, a 10 percentage carbamide peroxide can split urea into 7 percentage urea, which can help to increase the hydrogen ion concentration, ammonia, carbon dioxide, and 3.5 percentage hydrogen peroxide. That is what is the main agent we require. Coming to sodium perborate, which is available in the powder form. When it is fresh, it contains 95 percentage perborate and corresponding to 9.9 percentage available oxygen. In the presence of acid or a warm air or water, it can decompose into sodium metaborate, hydrogen peroxide, and nascent oxygen. This sodium perborate in clinical uses, it is available in three forms, three preparations, that is monohydrate, trihydrate, and tetrahydrate. Okay. Now coming to the adverse effects of bleaching. So coming to the vital bleaching techniques, the main adverse effect is the sensitivity that the patient can complain of. So the sensitivity can be managed by giving the patient a desensitizing toothpaste prior and also throughout the treatment. Then during the procedure of a power bleaching or an inside outside bleaching or a walking bleach technique, in any of the procedure, whether it being a vital bleaching or a non-vital bleaching, the application of a rubber dam is mandatory, as these agents can cause caustic issues to the soft tissue or any soft tissue injury, allergy, etc. So that the non-vital bleaching is again one of the main contraindication is grossly destructed tooth. If almost more than 20 percentage or more than 50 percentage tooth structure is lost, never go for a non-vital bleaching technique. And also the adverse effect of a non-vital bleaching technique is cervical resorption. That is the main disadvantage of a non-vital bleaching. So these two we should not remember. Non-vital bleaching, the adverse effect is cervical resorption, and for vital bleaching it is the sensitivity. And for both of this, without using a proper isolation or a rubber dam technique, both these techniques can cause soft tissue injury plus inflammation and epithelial sloughing. So this is the individual adverse effect, and this altogether soft tissue injury, inflammation, and epithelial sloughing. So these are the main adverse effects of bleaching. So coming to the conclusion, proper diagnosis of the case, whether it is the intrinsic stain or if it is an extrinsic stain. So based on this, our treatment modality can be modified. So proper diagnosis of the case and the proper treatment outcome is obtained only when the diagnosis is accurate. Okay, so thank you.